Key findings in liver diseases for practitioners. In our country of 1.5 billion people, less than 2,000 transplants are performed every year. The challenges of diagnosing and managing patients with liver disorders in India are similar in comparison to the rest of the world. Illiteracy, lack of healthcare facilities in rural areas, absence of universal healthcare, and prevalent malnutrition are factors adding to the challenges. Clinical features or signs and symptoms of liver disease. Since many of the clinical features of chronic liver disease are related to the failure of the liver to carry out its normal functions, we will be discussing them in this video, such as jaundice or icterus. Jaundice in adults is yellow discoloration of the skin and whites of the eyes, which usually occurs when serum bilirubin is greater than 50 micromoles per liter. Spider nevi. Spider nevi are small vascular malformations, arterial venous shunts that occur in the skin and hands. They are not specific to liver disease, but may indicate impaired liver function. Palmar erythema, red palms of hands, also occurs commonly in chronic liver disease. Bruising and bleeding. Patients with chronic liver disease often experience increased bleeding from the gums and mouth and easy bruising. This is primarily related to abnormal clotting of blood caused by a reduced ability of the liver to synthesize clotting factors. Encephalopathy. Hepatic encephalopathy (HE) is a neuropsychiatric syndrome that occurs in patients with significant liver dysfunction. Characteristics of HE include reduced concentration, confusion, changes in sleep pattern, and asterixis, also known as the hepatic flap, which presents with hand tremors and inability to keep the wrists extended on outreached hands. The precise pathogenesis of HE is unknown, but it is widely accepted that this complex syndrome results from the failure of the liver to remove gut-derived toxins. Portal hypertension. Portal hypertension is increased pressure within the portal venous system as a result of increased resistance to flow through the damaged liver. Collateral veins develop, and these can bleed due to the increased flow and pressure within. Splenomegaly. Splenomegaly can be caused by increased pressure in the portal venous system and indicates portal hypertension secondary to cirrhosis. Varices. Esophageal and gastric varices are abnormally dilated collateral vessels in the esophagus or stomach, which arise as a result of portal hypertension or obstruction. These varices enable blood to bypass the liver as a means of reducing the portal pressure or bypassing the obstruction. If the pressure in the vessels becomes too high, they can burst, leading to massive hemorrhage. Gynocomastia. Gynocomastia can occur in men with liver disease because of the inability of the cirrhotic liver to metabolize estrogen. In women of reproductive age, this effect on sex hormones can reduce fertility. Laboratory and image findings. The laboratory and imaging test are the crux of confirming the condition and consequent treatment regimen plan. In the laboratory test, the biochemical markers such as serum bilirubin, alanine aminotransferase, aspartate aminotransferase, the ratio of aminotransferases, alkaline phosphatase, gamma-glutamyl transferase, 5' nucleotidase, ceruloplasmin, alpha-fetoprotein are tested. Most of these biomarker enzymes are found to be elevated in the blood serum during liver disease and injury. However, their levels can be ever-changing or stagnant, such as the levels of AST or ALT were seen to be normal in many hepatitis patients. Ultrasonography, or the first line of imaging modality, is for screening of biliary tract abnormalities, imaging the hepatobiliary tract in patients with drug-induced liver injury, and screening of liver masses for hepatitis or tumor. A study conducted by Christoph et al. Echoed the same sentiment by concluding that conventional ultrasound imaging remains a valuable tool in the initial diagnosis of liver diseases. It plays an important role in the assessment of liver steatosis and bile duct diseases. Ultrasound techniques enable a reliable assessment of liver fibrosis, and enriching ultrasound imaging with contrast agents allows focal lesions in the liver to be identified and differentiated correctly. CT identifies hepatic masses, particularly small metastases, with a specificity of more than 80%. CT with IV contrast is accurate for diagnosing cavernous hemangioma of the liver, as well as differentiating them from other abdominal masses. CT can also differentiate a parenchymal attenuation caused by hepatitis. Further, Rovsky et al. Demonstrated the characteristic alterations of liver attenuation on CT, signal changes on MRI, and morphological changes appreciated with both modalities can be used to diagnose fatty infiltration, some parenchymal deposition diseases, and cirrhosis. MRI, as discussed, can also be used to visualize blood vessels without using contrast, ducts, and hepatic tissues for quantifying liver fats in NAFLD patients, or exclude other etiologies or deranged serum liver function tests, such as a possible mild generalized increase in parenchymal signal intensity in case of hepatitis. A study conducted by Towley et al. Stated that with the continued increase in the prevalence of liver disease, mostly due to NAFLD and HCV infection, MRI will play an increasingly important role in the evaluation of patients with chronic liver disease due to the lack of ionizing radiation and the possibility of performing multi-parametric imaging combining conventional and functional sequences.